Welcome to Wound Care Wednesday episode 3. I am Laurie. If this is the first time you've been here, I am a family nurse practitioner and I do wound care as a specialty. I have this series going on where every other Wednesday I talk all things wound care related. I have compiled the videos for Wound Care Wednesday in a playlist. So if wound care is the only thing that you're interested in my channel, it's easier for you to follow along in the videos and to watch all of those. I will link it in the cards and also in the description box down below. Make sure that you are subscribed to the channel if you have not yet subscribed, and also click your notification bell so you are notified every time I upload a video. In today's episode, I am going to be talking to you guys about what you want to document when different types of wounds come into your facility. Oftentimes, I feel like nurses kind of get scared and they don't know what it is that they're looking at. I'm going to go through some of the wounds that you will probably typically see coming into your facility or your unit and what you want to document for those wounds. A lot of times the wound care team, myself, get consulted on a lot of things that are not wound care related, and some of those things are pretty much dermatology, skin rashes, different things like that. I'll probably make a separate video talking about skin rashes, so let me know if you want that. Now, one of the biggest things we get consulted about, as we all know, is pressure related injuries, and in episode 2 I touch on how to stage pressure related injuries, because we do know that we have stage 1, 2, 3 and 4, and we also have unstageable. I'll put a picture on the screen to kind of differentiate each of them for you guys. Bear in mind and also know that for pressure related injuries, you mostly find them on bony prominences like the elbows, the malleolus, the coccyx, the hips. These are the typical places you will find a pressure related injury. There is also something that is termed Dtpi, deep tissue pressure injury, and a Dtpi normally looks darkened area on the lateral bed of the foot. Sometimes we see it on the heel, we see it sometimes on the coccyx. It's not yet a pressure injury, and those definitely can and will become a pressure ulcer, whatever stage, once they open up. Sometimes the patient will say to you, my heel hurts really bad, and when you take a look at the bottom of the heel, you see a small area. It's formulated into a deep tissue pressure related injury. A lot of times it's hard to identify in persons who are of darker skin tones, but if your patient is telling you that yes, something is there, even though you're saying I can't see anything, they're telling you it's just painful right there, you have to try to protect that area. Then we have things like moisture associated skin dermatitis. Now, a lot of times when your patient is incontinent and your patient is in bed, they get this extreme redness to the bottom area with different ulceration on the bottom, and a lot of nurses tend to want to say it's a pressure ulcer. A lot of times it's not pressure related, it's moisture associated skin dermatitis is what we term it. And what we tend to do with those, even if there's some ulcerations on there, you can use your barrier creams for those on the skin, like your Calmoseptine or your Sensicare, whatever your facility use for moisture. Then there is a ulceration that we call Kennedy ulcers. So your Kennedy ulcers are normally seen on the sacrum and the coccyx area, and Kennedy ulcers are pretty much ulcers that deteriorate quickly on a patient. A lot of times when patients are in the process of expiring, they tend to develop these ulcers. The nurse will probably say to you, I was here 2 days ago and the patient did not have that, and it rapidly deteriorates. It normally looks like a butterfly and it deteriorates quite quickly. The next thing are skin tears. A lot of us can identify skin tears. We don't have problems with identifying skin tears. A lot of times patients are at increased risk when it comes on to getting skin tears, because skin is a little bit more fragile, and a lot of tape that we use on some of these patients in the hospital setting and the nursing home setting cause their skin to rip, and we kind of have to be careful with that. The next type of wounds that we normally see are venous insufficiency ulcers and arterial insufficiency ulcers, and I'm gonna make a dedicated separate video about venous and arterial insufficiency ulcer and just kind of go over each of these, because I don't want this video to be too long. You normally tend to see these ulcers on the lower legs, on the dorsal of the foot, posterior, lateral, anterior parts of the leg, and 9 times out of 10, if you ask the patient how long they've had these ulceration and they tell you I've had it 6 months, I've had it a year, and it's just not healing, a lot of the times it is arterial or venous insufficiency that is causing those ulceration on those patients' legs. When it comes to treating this, of course, in episode 2, I also talked a little bit about how you treat different type of wounds, because one medication is not specific for arterial ulcer versus a pressure related injury. And I touched on that in episode 2. If you've not seen episode 2, check it out, and they give you a little bit more clarification on how to treat these. But that's how you kind of identify the wounds on the lower part of the legs. A lot of times patients are diabetic, and diabetes is one of the risk factors for patients to have arterial insufficiency. It can be a combination of diabetes and arterial insufficiency is what causing those wounds. Of course, we do have surgical incision and surgical wounds. Easy for you to kind of identify that, okay, this is a surgical wound that probably dehisced or whatever is going on with it, got infected and different things like that. So that's probably another easy one for you guys to identify. Then of course, we get consulted on different things like cellulitis, boils, abscesses, different things like that. With patients who have cellulitis, the best way that I can describe cellulitis is the area is there's some redness. You can have some ulceration on the area of a patient that has cellulitis, and sometimes it's warm. And I have seen patients where there's not much warmth there, but it is cellulitis that is developing on the patient. Sometimes you have what we term superficial cellulitis, and I've seen superficial cellulitis even on patients' fingers where they do get just a small cut there, and it started getting a little bit red and just painful to the touch to that area. So that's pretty much all the wounds that you will probably be seeing and different things that you will be seeing coming into your facility and how to quickly identify them. Let me know in the comments if you have any questions. Once again, don't forget to like, comment, and subscribe, and I'll definitely catch you guys up on my next video. Bye guys.